Bom dia. Thank you very much for having me. And today I'm going to talk about the advanced life support tools associated with the HeartStart Intrepid. The three primary tools that I'm going to focus on are the TBI Advisory, Q-CPR, and DXL algorithm. Now, before we can talk about the TBI Advisory, we need to understand a little bit more about TBI and secondary injury associated with traumatic brain injury. So in the United States, there are approximately 2.2 million traumatic brain injuries per year. Of those, 280,000 result in hospitalizations and 52,000 die. All of this comes at a cost of $60 billion per year. Now, in Brazil, there are approximately 125,000 hospitalizations per year and 10,000 deaths due to traumatic brain injury at a cost of $71 million per year. However, these numbers may be understated because of underreported incidents of trauma in Brazil. So what happens when a patient suffers a traumatic brain injury? So TBI occurs when the brain impacts the skull and causes damage to the cerebral tissue. There are two injuries associated with TBI, the primary injury and the secondary injury. The primary injury occurs at the point of impact and consists of bruising, swelling, and bleeding of the brain tissue. The secondary injury is the body's response to the injured cerebral tissue. This causes additional edema, autoregulation issues, ischemia, and toxicity. However, some of the cerebral damage from secondary brain injury is preventable. And today we're going to identify the areas where the HeartStart Intrepid TBI Advisory can potentially impact patient outcomes by decreasing secondary injury, or at least helping providers decrease secondary injury. Now, according to the National EMS TBI guidelines, it's important to avoid three critical factors associated with maintaining adequate cerebral oxygenation and perfusion and preventing secondary brain injury. And those three factors are hypoxia, hypotension, and inadvertent hyperventilation that leads to hypocapnia and cerebral vasoconstriction. So let's start by talking about hypocapnia due to inadvertent hyperventilation. So as a medic many years ago, I remember how chaotic it was to treat and transport a patient who had had a severe traumatic brain injury. Not just because TBI is bad, but because traumatic brain injury is usually associated with multi-system trauma. It's easy to lose perspective on time and end up trying to get the ventilation rate of a patient to be appropriate when you yourself are breathing at 20, 25 times a minute. You tend to try to match the patient's ventilation rate with your ventilation rate. But in essence, it's very difficult to maintain adequate rate and volume of ventilations as you're trying to manage a trauma. Now, recently, to kind of drive the point home, recently the San Diego RSI trial found that 79% of patients that were intubated before arriving to the hospital experienced at least one incident of hyperventilation, resulting in an EtCO2 of less than 30 millimeters of mercury. In addition, 59% of those patients experienced at least one incident of hyperventilation, resulting in an EtCO2 value of less than 25 millimeters of mercury. Also, this means that the maximum ventilation rate was 36 ventilations per minute, with the lowest EtCO2 being 23.5 millimeters of mercury. Now, when you consider how vasoconstriction and EtCO2 are related within cerebral circulation, you begin to appreciate how significant those numbers are. So, for example, if you happen to have an EtCO2 of 40 millimeters of mercury and you tend to drop 10 10 millimeters of mercury, you're looking at a 20% decrease in cerebral blood flow. The relationship is so sensitive that a 5 millimeter drop in, a 1 millimeter drop in ETCO2 is equal to a 5% drop in cerebral blood flow. So it's very precarious. Now, one of the things that's important to note that the researchers found about our San Diego RSI study is that those patients who were transported by paramedic crews who used capnography to guide their ventilations had a lower incidence of hypocapnia than the patients transported by paramedic crews that did not use capnography. So going back to our diagram above, our previous diagram, my apologies. Going back to the previous diagram, you can see here that when you happen to have hypocapnia, that leads to vasoconstriction. The vasoconstriction then leads to decreased cerebral blood flow. You have additional cerebral hypoxia, which then leads to cerebral edema, and it creates this consistent cycle of increased intracranial pressure and ischemia within the brain. So we want to try to prevent inadvertent hyperventilation as much as possible. Now, let's discuss hypotension and hypoxia and its effect on patient mortality. So in the United States, a study was conducted, and it was called the Excellence in Pre-Hospital Injury Care TBI study, or also known as the EPIC TBI study. It was conducted over a 7-year period and consisted of approximately 13,000 patients who had suffered moderate to severe TBI. There were many aspects that the researchers looked at, but some of the more surprising findings that they had was that patients who experienced one incidence of hypotension only had a mortality of 20.7%. The patients who had hypoxia only had a mortality of 28.1%. But those patients who had an incidence of hypotension and hypoxia combined had a mortality of 43.9%. It's a pretty startling number, right? So obviously almost half of the patients who had hypotension and hypoxia dying is pretty bad. But what's even more surprising is that a patient who experiences both hypoxia and hypotension has a 600% higher likelihood of dying than someone who experiences neither of those two. One of the other important findings of the EPIC TBI study was the absence of any identifiable systolic blood pressure threshold in relation to patient mortality. So normally what we would look at is we would look at trying to maintain a blood pressure above 90 millimeters of mercury, and that's usually the standard for considering a patient hypotensive in a trauma scenario. But what the EPIC TBI found is that a systolic blood pressure with a range of 40 to 120 millimeters of systolic blood pressure, there was a consistent decrease in survival for every 10 millimeter drop in systolic blood pressure, and a progressive association between decreasing systolic blood pressure and both unadjusted and adjusted risk of death. So what does this look like in regards to patient mortality and blood pressure? So what this looks like is that a systolic blood pressure of 60 millimeters of mercury, a patient with a systolic blood pressure of 60 millimeters of mercury is 4 times as likely to die than a patient with a systolic blood pressure of 135 millimeters of mercury. So that classic 90 millimeters of mercury may actually be too low, because the injured brain is so sensitive to a lack of perfusion that secondary injury begins to occur at a much higher blood pressure than one would expect. Some of the other important findings from the EPIC TBI study was that when the researchers worked with Arizona EMS agencies to implement the pre-hospital TBI guidelines, they focused on three areas: preventing treating hypoxia with high flow O2 and basic airway maneuvers. So what they looked at was trying to get away from the need and desire to intubate a patient immediately in the field. This could lead to hypoxia secondary to delayed ventilations. Patients, medics trying to get the tube, they keep missing, and you have a longer gap of hypoxia. The other thing that they looked at was preventing and treating hypotension by rapidly infusing hypotonic fluids, and lastly, preventing and treating hyperventilation by using appropriate ventilation rates, adjuncts, and ETCO2 monitoring. So this is what they found. They found that the adjusted survival to hospital discharge doubled for patients with severe TBI and tripled for patients with severe TBI that also received positive pressure ventilation via bag valve mask or an endotracheal tube. The increased survival of patients with severe TBI receiving positive pressure ventilation was attributed to the emphasis on maintaining ETCO2 between 35 and 45 millimeters of mercury and utilizing rate timers that gave visual cues for proper manual ventilation and using flow-controlled ventilation bags to help prevent hyperventilation and overventilation. So instead of letting the ETCO2 drop below 35 millimeters of mercury, the medics really focused on keeping it between that, in that very narrow 10 millimeter mercury window, to make sure that the brain that the blood vessels in the brain were not constricting. And one of the most important findings of the EPIC study was that the initial improvement of patient survival faded over time. Now, this was most likely attributed to the fact that the researchers could not require the paramedics to maintain training on the TBI guidelines. So there was less training, less emphasis, and ultimately as time from training to incident increased, the medics started to lose some of the focus on maintaining on preventing hyperventilation, preventing hypoxia, and preventing hypotension. What the authors concluded is that the use of monitoring technology that can give visible cues and real-time feedback to providers during the resuscitation of brain-injured patients could improve outcomes by helping to prevent secondary brain injury. So in other words, if you had a device that gave you feedback, much like a Q-CPR meter that we're going to talk about in here shortly, if you had a device that gave you that feedback, it would be a lot easier to look at your patient and see trends that are beginning to occur and stop them before you get to critical levels. So, and also all of these references are listed in the back of the PowerPoint presentation. So let's talk about the HeartStart Intrepid and the TBI Advisory of the HeartStart Intrepid. One of the important things to remember about the TBI Advisory is that its sole purpose is to assist in the monitoring of patients who have been determined at a high risk of having suffered a traumatic brain injury. Now, the TBI Advisory provides a visual guidance that reflects the appropriate target limits. Now, those target limits are set by the medical control and local protocols. So if your medical director says that I want the TBI advisory to appear, the systolic blood pressure TBI advisory to appear at 120 systolic blood pressure, then they can go ahead and set that. They don't have to set it to 90 or anything like that. So it gives a lot of leeway and latitude for agencies to set their own protocols. The TBI advisory, it'll measure hypoxia by pulse oximetry, hypotension and systolic blood pressure, and hyperventilation or hypocapnia due to hyperventilation by ETCO2. The thing about the TBI Advisory is that it's available for both adult and infant and child patients in monitoring mode. But it has the device has to be configured with SpO2, non-invasive blood pressure, and ETCO2. So you need all three of those features on the device to be able to utilize the traumatic brain injury. Now, let's go ahead and contextualize what this would look like, how the TBI Advisory could potentially help medics and pre-hospital providers prevent secondary injury. So let's take this scenario, for example. So the paramedics are called to a motor vehicle collision, as you can see in the image. Once they arrive on the scene, they find Marcos, a unresponsive 43-year-old man with slow, shallow breathing and a rapid pulse. The paramedics also note that he has a hematoma on the forehead and a contusion to his abdomen. So we're looking at thoracic trauma as well as traumatic brain injury. So at this point, Marcos needs to be extricated from the vehicle, packaged for transport, and transported to a hospital with neurosurgical capabilities. Now, the closest hospital with neurosurgical capabilities from the scene is approximately 30 minutes away. And of course, air rescue or helicopter transport is grounded due to weather. So we're going to have this patient in the back of an ambulance for a long time, to include a prolonged extrication time to even get going. So when they load the patient in the ambulance and they take the patient's initial vitals, the TBI Advisory indicates that the patient has an SpO2 of 92%. Now, what happens in this instance is the medic, the TBI Advisory goes off, right, because they set it at higher than 90%. They weren't waiting to see a low ETCO2 of 85%, or I'm sorry, low SpO2 of 85% or something like that. They wanted to catch it before the patient became hypoxic. So to compensate for the reduced breathing, because the patient was breathing at about 5 breaths per minute, the medic began positive pressure ventilation. Now, of course, the medic was excited. They just extricated this patient. It's a multi-system trauma, and they began ventilating the patient at about 22 ventilations per minute. Now, obviously, that has a detrimental effect that we'll talk about in a second. So if you're looking at the screen right now, this is an enlargement of what the TBI Advisory would look like for SpO2. So you would have the SpO2 reading here on the left and the pulse rate on the right of the little window. And if TBI was below, if SpO2 was below limits, you would get this yellow indicator. And if it was above limits, you would get the TBI Advisory would stay green. So unfortunately, as the medic was ventilating the patient, the medic inadvertently hyperventilated the patient. So he's ventilating at a rate of 22 ventilations per minute, and they start to notice that the ETCO2 starts to fall. So once again, instead of waiting for the ETCO2 to reach a level below 35 millimeters of mercury, maybe the medical control called for the TBI Advisory to identify a low ETCO2 at 35 millimeters of mercury before we hit that critical level. So the medic at that point recognizes that the patient is starting to be hyperventilated, and the medic slows down his ventilations and was able to prevent hypocapnia and hypocapnia by hyperventilation. And this again is what the TBI Advisory would look like on the HeartStart Intrepid display. One of the things that I do want to point out, though, is that on the left you have here the ETCO2 reading, but on the right you happen to have the airway respirations, and this is the respirations that are captured through the endotracheal tube or ETCO2 sensor. Now you can connect the EtCO2 sensor in line with a bag valve mask, and you will get a good reading as long as you have an adequate seal on the bag valve mask or on the mask itself. Ideally, you want the patient intubated. So as the crew continues to the hospital, right, the medic notices Marco's heart rate is beginning to gradually increase and his blood pressure begins to drop. However, the TBI Advisory systolic blood pressure lower limit was set to 100 millimeters of mercury because, once again, they didn't want the patient to get hypotensive. They wanted to prevent it and stop it before it became an issue. So before the patient was able to become dangerously hypotensive, the medics were able to infuse hypotonic fluids and maintain the patient's systolic blood pressure. Hopefully, we would hope that, the patient made it to the hospital, Marcos, and was able to survive the incident and whatnot, but it's a simulation scenario, and I didn't take it that far. And this is, again, the blood pressure as it would look like on the HeartStart Intrepid. So there's a couple of key points that we need to remember. A couple of key points that we need to remember. So TBI is a global problem that has significant societal and economic impact on countries and the world as a whole. Maintaining the 3 H bombs, or the 3 critical factors associated with traumatic injury within the guidelines, has a significant impact on patient survival. The other thing to consider is that a patient with a single episode of hypoxia is 3 times as likely to die than a patient who does not have hypoxia. A patient with hypotension is 2.5 times as likely to die, and a patient with hypoxia and hypotension is 6 times as likely to die. One of the other things is that there is no threshold, no systolic blood pressure threshold in traumatic brain injury, and preventing hypoxia and by using high flow O2 and basic airway maneuvers, preventing hypotension by rapidly infusing isotonic fluids, and preventing hyperventilation by using appropriate ventilation rates, adjuncts, and EtCO2 monitoring can help prevent patient decline due to the 3 H bombs. Patient mortality increases as training fades. This is an important thing to consider, is it doesn't matter how well your medics or ambulance crew are trained, that if they don't practice, if there's not an emphasis, then the focus tends to decrease and you'll start getting out of the parameters. And lastly, the TBI Advisory provides visual guidance that reflects the appropriate target limits for each TBI care parameter, and in the hopes that if the device were to give the advisory that the EtCO2 were low, then the medic or whoever is providing ventilations or whatever would begin to correct the condition. So let's go ahead and talk about Q-CPR or quality CPR, the Q-CPR function of the HeartStart Intrepid. So, sorry, I had to move the window around. So, quality CPR has a direct impact on sudden cardiac arrest survival and ultimately patient outcomes. Because just because you survive cardiac arrest, you get return to spontaneous circulation, or you happen to get discharged from the hospital, doesn't necessarily mean that you have a good neurological outcome. And quality CPR can help improve those outcomes. But as those of us who have performed CPR know, performing quality CPR is difficult. And as a whole, caregivers have a difficult time meeting the established American Heart Association and European Resuscitation Council guidelines for compression rate and depth. Also, there's difficulty in completely releasing the chest, and there tends to be longer CPR pause times than what we would like, and ultimately ventilation rates tend to be too fast. The important thing to consider in regards to performing quality CPR is that the AHA found it so important for folks to get feedback when performing chest compressions that they required as of 2019 that all AHA CPR training include a device that measures CPR performance and provides real-time feedback to the student. So if it's important to do in training to help the student meet the guidelines and the parameters of quality chest compressions, then why wouldn't it be important in a real life scenario? So let's talk about the Q-CPR function on the HeartStart Intrepid. So the Q-CPR function works in conjunction with the Q-CPR meter, the multifunction defibrillation electrode pads on the connected to the monitor. The Q-CPR function provides audio and visual feedback on compression depth, rate, chest recoil, CPR pause time, and ventilation rate on adults. The function cannot be used on children younger than 8 years old or weighing less than 25 kilograms. It's not calibrated for the depth for providing chest compressions on the children. During use, the Q-CPR meter 2, which we'll refer to as the Q-CPR meter, measures chest compression depth and rate, while ventilation rate is analyzed through chest impedance through the multifunction electrode defibrillation pads. And this is interesting because what that means is that you don't need to be connected to ETCO2 to see how fast you are ventilating the patient. If the chest compression rate or CPR pause time or ventilation rate is outside of the pre-established limit, the device will provide visual indicators and audio prompts to help the rescuer maintain CPR performance. Now, in manual mode, the manual defibrillation mode, the audio prompts can be disabled. When placing the Q-CPR meter, when utilizing the Q-CPR meter, the pads need to go in the anterior lateral position, as you can see in the image, and the Q-CPR meter needs to be applied to the center of the chest. Once the Q-CPR meter begins chest compressions, you begin to see things on the display. Now, right now we're looking at the manual mode display, and I'm going to go ahead and zoom in some on the display here so you can see what I'm talking about. So the Q-CPR display is comprised of 2 sections. You have the waveform compression section, and then down below you have other CPR information such as compression, total compressions, CPR pause time or no CPR time, and a CPR timer. So the compression depth is displayed on a waveform in wave sector 2, and it represents about 10 seconds of compressions. A chest compression is represented as a downward stroke of the waveform, and it's returned to baseline once complete pressure is released. To measure the adequate compressions, you have these 2 lines down here, and one is set to measure 50 millimeters of mercury. I'm sorry, see, I've been talking about ETCO2 too much. Is to measure compressions at 50 millimeters or 60 millimeters. So if you're within that target range, that's considered an effective compression. If the compression is not completely released, then you will see an asterisk on the waveform indicating that the compression has not been released. Now, that doesn't necessarily do a lot in the moment of providing chest compressions, but when you review data, you can see how the medics performed, what chest release was, and this can help improve CPR performance of the rescuer. To the right of the waveform, you can see the compressions per minute rate is displayed in compressions per minute, and the ventilation rate that's collected from the multifunction pads is listed to the right of the compression rate. And as I mentioned previously, down in the bottom section, in the second section of the Q-CPR display, you have total compressions and no CPR time, which starts at 2 seconds of no compressions and then increases after that. So this is the Intrepid in AED mode, because you can use Q-CPR in AED mode. And it's one of the important things to remember, as I mentioned previously, is that ventilation rate can be captured in AED mode. You don't need an endotracheal tube. You don't need to be have some type of rescue airway in place. You can detect ventilation rate utilizing a back valve mask, because the ventilation rate is detected through the pads, not through the airway. Q-CPR in AED mode and manual mode, the display isn't very different. Obviously, in AED mode, you get the prompts and the feedback and whatnot. But in manual mode, the prompts are not enabled by default. So as you're doing a cardiac arrest as a paramedic, it may be a little, it may not be necessarily that good when the device is sitting there telling you push harder when you're in front of the family. So as a whole, most folks like to disable that unless they really need to have that audio feedback. Now the Q-CPR meter, as you can see on the left of the screen here, it is placed in the center of the chest, and you place your hands over it just like you would if you're performing standard CPR without the meter. And as soon as you begin compressions, the screen on the CPR meter begins to light up, and you begin to see the compression rate target, the compression rate indicator, release target. So you see all these parameters for chest compressions. Taking a closer look at the Q-CPR meter display, you can see that the compression depth indicator will show a bar at the top that lights up white with complete release. You see a bar at the bottom that lights up once you hit the depth of 50 millimeters or 60 millimeters. I'm sorry, the depth between 50 and 60 millimeters. If you're not compressing deep enough, then you'll see a yellow arrow that indicates that you need to press harder. If the compression depth is greater than 70 millimeters, then you'll see the white bar, the compression bar highlight at the depth of compression, but you'll also see an indicator below the compression bar. If you're not releasing fully, or if you're still leaning on the chest, then you'll see a yellow arrow that begins to show that you need to completely release, and the bar at the top will not turn white. The other thing that the Q-CPR meter happens to have, it has a compression rate indicator. It's a little speed dial speedometer. And if you are compressing too slow, it'll go over to the left. And if the device is set up to provide audio prompts, it'll begin to tell you compress faster or push faster. And if you are compressing too fast, then the device, the indicator will tap on over to the right, and you'll get an audio prompt telling you to compress slower. You will also see a stop CPR in AED mode when the device is analyzing. and a no compression detected indicator if obviously you're not providing chest compressions. One of the key things to remember with the Q-CPR meter is that you do not have to remove the meter during defibrillation. You can leave it on, it's perfectly fine. This next table are the verbal prompts of the Q-CPR meter. I'm not going to go into detail of the verbal prompts because you can see them there on the screen. So let's go ahead and talk about the DXL 12-lead ECG algorithm on the HeartStart Intrepid. One of the neat things about the HeartStart Intrepid that I like to point out is that when you look at it, we provide all 12 leads present on the screen of the ECG. So on the screen, so you can see right there, all 12 leads are visible, so that you can make sure that you have good signal quality before you begin acquiring the 12 lead. Now, the DXL algorithm in the HeartStart Intrepid analyzes 12 leads of simultaneously acquired ECG waveforms to provide an interpretation of rhythm and morphology across a wide variety of patient populations. Some of the features of the DXL algorithm are ST segment elevation, myocardial infarction, culprit coronary artery, or STEMI-CA, criteria that suggest the probable site of occlusion. It uses updated diagnostic criteria such as global ischemia due to left main or multi-vessel occlusion, and it has enhanced critical value statements to highlight conditions requiring immediate clinical attention. So the analysis process that the DXL algorithm takes to make a decision is 3 steps. It does an acquisition and quality assessment, it does waveform recognition and measurement, and it applies specific ECG criteria. Let's go ahead and break down those steps. So the DXL algorithm acquires and assesses the quality of the ECG. Then it runs the waveforms through a pacemaker detector module, and if a pacemaker is detected, the algorithm analyzes the pacemaker rhythm and matches it to a known representation of the rhythms that you see listed on the screen. In the second step of the process, the Q-CPR, I'm sorry, still on the Q-CPR, the DXL algorithm utilizes a QRS detector to identify beats, and the dominant family of beats is aligned and averaged per lead, with the outliers removed and averaging conducted to reduce noise for the represented beats. So in other words, it cleans up the ECG and identifies which one of the beats are the most dominant. The measurements are made on individual and representative beats, and global measurements are chosen from the stable leads. And in step 3, the DXL algorithm applies the interpretation criteria and chooses the correct statement output. You can see some of the outputs, and we'll talk about those in more detail here in a minute. So ST segment elevation and ECG tracings are highly indicative of acute coronary syndromes. Certain ST segment elevations have earned such names as the Widowmaker or Tombstone T-waves because they are so deadly. Now, the ultimate goal of identifying an acute myocardial infarction is to minimize damage to the myocardium by removing the blockage from the coronary artery as quickly as possible. So this is accomplished by reducing door to balloon time or discovery to treatment time. Now, I remember being as a paramedic in the early 2000s, and we didn't necessarily have 12-lead ECGs in the field back then. And if your patient had chest pain, you might be able to see some ST elevation in one of the 3 leads you had available. But once you got the patient to the hospital, you still had to wait for the 12-lead ECG to be done in the emergency room before they can be transported to the cath lab. Other times, what we experience is that the only facility with a cath lab was on diversion, because usually those tend to be your teaching hospitals, your university centers, and they tend to get very busy. And if you couldn't make a good case for your patient to go to the closest facility, you had to transport them to the next closest facility with a cath lab, and that could be 20 minutes away or more. So that whole time you have cardiac muscle that's dying, and you can't do anything about it. Now, there are certain difficulties with STEMI diagnosis. Pardon me. With STEMI diagnosis, such as in the early phases of the myocardial infarction. So SC segment elevation can be intermittent, and the patient could be having coronary spasms where the SC segments are elevated and then go back to normal. So it's important to get a quick analysis of the ECG, so that way you can catch those ST segment elevations. The other problem with STEMI diagnosis is that you have other causes, such as like pericarditis or medication such as digitalis, and persistent ST elevation after the myocardial infarction has become chronic. So you have ST segment elevation that's not actively killing muscle tissue. Now, to overcome some of the difficulties of the DXL algorithm, the ECG needs two adjacent leads with sufficient ST elevation, and it uses the greatest ST elevation lead to make the decision. It also suggests a culprit artery only when the STEMI findings are strong enough to avoid false positives. Now, speaking about the STEMI CA for identification of the culprit artery. So what it looks like is that if STEMI criteria are met, the DXL algorithm STEMI culprit artery criteria identify the culprit artery as a probable anatomical site using the functional ischemia. Now, this can have prognostic significance because it can help pinpoint the culprit lesion when there happen to be multiple obstructions present, and hopefully it could optimize the treatment approach in the cath lab. And you can see the arteries that the algorithm looks at in the image. So there are some additional benefits that you can get from the STEMI culprit artery, such as supplementing angiography that may show chronic lesions and could identify obstructions that aren't necessarily the cause of the myocardial infarction. On the screen, you can see that there are some critical value statements. Now, these critical value statements are printed out on the 12-lead ECG report, and their main goal is to trigger EMS personnel to initiate their STEMI protocol, and hopefully would help them make sure that they transport the patient directly to a cardiac specialty hospital. The DXL algorithm also uses gender, age, and lead-specific ECG interpretation criteria to make a decision on the diagnosis. And so these are some of the gender criteria that the DXL algorithm looks at for identifying differences in ECGs. Between men and women. Also, the pediatric criteria, there are 12 distinct groups that go from days, weeks, months, and years to make sure that you're getting the most age-relevant reading. Also, there's a QT analysis that measures the interval and various QT interval corrections, and it makes T-wave measurements. Lastly, there's advanced pacemaker detection, and to help identify and clear out pacemaker noise and to make an appropriate 12-lead ECG decision. So the next 3 slides are the references. If you so happen to want to look at some of the studies that I discussed here in the presentation. So thank you for your time. And before we go, there's a couple of things that I would like for you to remember. Before we go, there's a couple of things I would like for you to remember, such as preventing secondary brain injury associated with traumatic brain injury by controlling hypoxia, hypotension, and hypocapnia can have a profound effect on patient survival rates. Performing quality CPR is very difficult, and the use of tools that can provide feedback can help improve CPR performance. And lastly, decreasing discovery to treatment or door to balloon time is critical for reducing myocardial damage during a heart attack. So thank you for your time, and let's see if we happen to have any questions.
Thank you, Max, for your presentation. I think Cynthia will gather some question. Let me ask. Oi, Cynthia.
Thank you, Max. Pessoal, voltando aqui, só para que vocês se sintam mais familiarizados, vou abrir para os questionamentos. A gente agradece em nome, né, da Philips, o palestrante, o Max, pela excelente explanação sobre os tópicos. Gostaria que vocês colocassem suas dúvidas a respeito das ferramentas. Alguma dúvida, pessoal? Acho que eu não estou conseguindo ver o chat. Pedi ajuda aqui. Ah, sim, agora abriu. O pessoal está parabenizando o Max. Bom, vou abrir algumas perguntas que eu recebi à parte aqui, tá? O pessoal tá tímido, não querem digitar no chat. O Arthur tá questionando se existirá muita diferença no uso do TBI para emergência extra-hospitalar e intra-hospitalar.
Okay. So our first question is there a huge difference between using TBI Advisory in hospital and outside the hospital? What will be the difference of the use?
Well, one of the interesting things about the TBI Advisory is that we're particularly looking at the pre-hospital provider and the early stages of TBI. Ideally, in the hospital setting, you would have other devices that can help maintain ETCO2 and blood pressure, and you would have hopefully enough staff to help mitigate any changes in blood pressure or ETCO2. Now, where that might change is in a mass casualty situation where you are out of patient monitors in the rooms, and you have to rely on utilizing the monitor defibrillator as a monitoring device.
Okay, understand. I see there is some more question dropping. Thank you, Max, for the first answer. So there is one question: is how is the use of Q-CPR in the US? This resource is widely used by most health services. How often is it used in the US, the Q-CPR?
I don't have a lot of numbers on that because that's oddly one of the things that I didn't prepare for. But utilizing Q-CPR, whether it's our device or whether it's another Q-CPR device, is widely used in the United States because it is roughly a standard of care. It's an unmentioned, unwritten standard of care.
Okay, thank you. And And there is another question regarding the Q-CPR, I think. There is a question, is there any resistance sometimes from the assistant team to use it?
Sometimes yes. And one of the things that I've realized, especially as training the military, is that if you embed the importance of identifying quality CPR and being able to provide feedback to help improve performance, if you embed that as an important thing in the organizational culture, then you don't get any resistance, or you get very little resistance. So it's important to make sure that you're integrating and you're training the crews to make that a part of the resuscitation process.
Okay, very clear. Thank you very much. Let me see.
A great presentation. Any use of these in obstetrics?
Like I said, I mean, you can utilize the device in a multitude of areas, but the TBI algorithm in obstetrics, I know that in the later stages of pregnancy, the vital signs and the blood pressure and whatnot can be a little bit different, and the TBI advisory, you can't change things on the fly for the TBI advisory. The Q-CPR meter, you can still use it on a woman who is pregnant because chest compressions still perform the same way. The meter still goes in the same location, so it can still be utilized.
Okay, thank you.
Mais questões, pessoal? No segmento time pré-hospitalar, que eu vi que eles estão em peso aqui. Alguma questão? Eu tenho uma pergunta, se você puder. Eu queria que ele desse o feedback dele, né, a experiência dele a respeito do uso do Q-CPR em pacientes pediátricos.
Okay. There's one question about how is your experience using Q-CPR in pediatric patients?
Well, I mean, like I said, you're not supposed to be using it with patients below 8 years of age or 25 kilos. So it's utilized out there, but once again, cardiac arrest in children is relatively low, so it's not necessarily utilized that often. A lot of the studies that we get are from adult patients, adult cardiac arrest.